A standard foot and ankle surgery equipment is generally adequate. In particular, the surgeon will need a straight lower bone ranger, a curved one, a 20 mm straight osteotome, a laminar spreader, a medium beater, a 2.5 mm Kirchner wire, a traditional 10 mm oscillating saw, and a spongostan hemostatic sponge. The SAAMBB procedure may be easily used for adult flatfoot correction with subtalar osteoarthritis, associated or not to posterior tibialis tendon degeneration. Other indications can be represented by wide subtalar bone coalitions, arthritic post-traumatic valgus hindfoot, or subtalar fusion revision. Under spinal anesthesia, the patient is placed in lateral position to allow an easier lateral approach to the subtalar joint of the affected limb. A tight tourniquet is applied and inflated for lower limb exsanguination. After the preparation of the subtalar joint and creation of the groove, the lower limb will be temporarily extra-rotated to allow the bone graft harvesting. Anatomical landmarks are represented by the tip of the fibular malleolus, the superolateral edge of the calcaneus, and the lateral aspect of the cuboid. A lateral 4 cm skin incision is performed over the sinus tarsi and posterior subtalar joint. The fat pad on the sinus tarsi and the capsuloligamentus structures are excised. At this point, the subtalar joint line is clearly visible, and the lateral process of the talus can be resected to improve the exposure. After the introduction of a laminar spreader to distract the posterior facets of the subtalar joint, the residual cartilage is carefully debrided with an osteotome and a lower bone ranger. The subchondral surfaces are then prepared and drilled with a 2.5 K wire to improve the recruitment of bone marrow mesenchymal stem cells. The subtalar joint is then manually reduced up to 5 degrees of heel valgus. This usually requires internal rotation and inversion of the calcaneus. The subtalar position is stabilized under fluoroscopic control with a 2.5 K wire positioned from distal to proximal into the talus. The site where the structural graft will be positioned is prepared with the help of an osteotome of proper size, generally a 20 mm chisel, carving a groove into the inferior surface of the talus and the superior surface of the calcaneus. The groove can be refined with the oscillating saw. The corticocancellous graft is harvested from the ipsilateral proximal tibia through a longitudinal approach centered over the anterior tibia crest, more or less 3 cm distal to the knee joint line. The 20 mm osteotome previously used can be useful to outline the dimension of the bone graft. A standard pneumatic oscillating saw is then used to cut the bone graft from the medial aspect of the tibia. Several cubic millimeters of additional cancellous bone can be obtained through the bone window by using a curette. Spongostan hemostatic sponge is finally used to fill the defect. The cortical graft is prepared to appear suitable and then vertically positioned along the axis of the tibia into the previously created groove, ensuring its stability. A medium beater is used to press fit the graft. The additional cancellous chips previously harvested are then positioned and pressed with the beater into the sinus tarsi and posterior subtalar joint to enhance the fusion. After accurate hemostasis, the skin is closed being careful of tension with interrupted absorbable number 30 suture.